Hello, our names are Emily Despain and Elizabeth Colell, and we are first-year graduate students in the Maryville University Speech-Language Pathology program. We received a grade for this project, but no other compensation.
Fluency is the aspect of speech production that refers to continuity, smoothness, rate, and effort. Fluency can be broken down into two categories, stuttering and cluttering. Stuttering, the most common fluency disorder, is an interruption in the flow of speaking characterized by repetitions of sounds, syllables, words, and phrases, sound prolongations, blocks, interjections, and revisions. All may impact the rate and rhythm of speech. These disfluencies can be accompanied by physical tension, negative reactions, secondary behaviors, and avoidance of sounds, words, or speaking situations. Stuttering can be referred to as disfluencies in speech. Disfluencies can occur with any speaker and include hesitations, interjections, non-word fillers, whole word repetitions, and phrase repetitions or revisions. When a child reaches a certain number of disfluencies, a diagnosis of stuttering can be considered. Alongside the increase of typical disfluencies, less typical stuttering disfluencies include part word or sound syllable repetitions, prolongation, and blocks. This type of disfluency can be accompanied with more tension. To determine the severity, the frequency, and the duration of disfluent moments, speech should be monitored. Three major components to stuttering are core behaviors, secondary behaviors, and feelings and attitudes. The term core behaviors was created by a researcher named Charles Van Riper, who grouped together a basic speech behaviors included in stuttering such as repetitions, prolongations, and blocks. An individual who is diagnosed with stuttering may also present with secondary behaviors. Secondary behaviors are the ways that individuals who stutter react to their core behaviors. Escape behaviors and avoidance behaviors are the two broad categories of secondary behaviors. Examples of escape behaviors are eye blinks, head nods, and interjections of fillers, such as and that are used to finish the word and terminate the stutter. An example of an avoidance behavior would be changing the target word because the speaker knows it will be difficult for them to say. The third part of stuttering is the client's feelings and attitudes. Feelings and attitudes can impact how the client feels about themselves. If they're embarrassed or anxious because of their stutter, they might project negative thoughts onto their listeners. Some believe that all three of these components must be addressed in therapy for lasting impacts to be made.
We will now share some background on stuttering. Stuttering typically develops in children around 2 years old, and approximately 95% of children who stutter will begin doing so by the age of 5. Stuttering has a multifactorial pathogenesis, which means that it has a multitude of causes and there is no one distinctive cause. The two main causes typically discussed in literature include genetic factors and neurophysiological factors. Other underlying factors may include environment, sex of the child, age of onset, and family history. ASHA reports that a link has been identified between gene mutations and stuttering. The three mutated genes that link to stuttering are the GNPTAB, the GNPTG, and the NAGPA. Many differences have been noted that have the potential to impact neurophysiological factors such as differences in gray and white matter, neural network connectivity, and atypical lateralization of hemispheric functions.
From examining the three components of stuttering, two major treatment techniques have emerged, fluent stuttering and fluency shaping. Although much debate exists on which technique is preferred, recently a combined approach of the two techniques has been used. Since controversy between approaches continues, this research aims to determine if any of the treatment approaches, fluent stuttering, fluency shaping, or a combined approach, have evidence-based practice support.
To conduct our research, the databases searched were ERIC, CINAHL Plus with full text, Medline Complete, PubMed, and Academic Search Complete. The keywords used were stuttering modification, fluency shaping, integration, combined, treatment or intervention or therapy, and fluency. And our inclusion criteria included individuals who stutter and studies that included the three approaches, fluent stuttering, stuttering modification, and a combined approach.
We will now go into detail about the information gathered through our reviews of literature. For fluent stuttering, researchers gathered qualitative information about clients' thoughts, feelings, and behaviors about their stutter. This information was gathered through surveys and questionnaires. Some of the surveys and questionnaires included were overall assessment of the speaker's experience of stuttering, OASIs, perceptions of stuttering inventory, PSI, locus of control of behavior scale, the Beck Depression Inventory, Multi-Component Anxiety Inventory 4, and State Trait Anxiety Inventory. The studies also used the Stuttering Severity Instrument, SSI, for children and adults 3rd edition, pre- and post-treatment to monitor stuttering severity. Based on these findings, not enough evidence-based research is available to use fluent stuttering as a sole treatment approach.
For fluency shaping, the research touched on behavioral treatment, prolonged speech, and rhythmic stimulation. Behavioral treatment was found to produce significant changes in the fluent speech of individuals who stutter with regard to respiration, laryngeal valving, and articulation. Another method, which focused on prolonged speech, showed clinically significant stuttering reductions in participants and was judged to be unnatural sounding. Feedback of speech naturalness ratings also revealed its use to integrate feedback with a prolonged speech treatment procedure and shape stutter-free speech into relatively natural-sounding speech, showing adequate construct validity and high reliability. Rhythmic stimulation is also useful in trying to improve the naturalness of improved fluency as stuttering was gradually reduced. Although these small studies did observe positive changes in the subjects, there is not enough evidence-based research to support fluency shaping as the sole treatment method for stuttering.
For the combined approach, treatment not only addressed the client's physical stutter, or core behaviors, but also secondary behaviors and the client's feelings and attitudes. After the clients participated in therapy that implemented the combined approach, phone calls and questionnaires were used to gather information on the client's feelings and attitudes towards their own stutter. Results indicated that the subjects maintained a satisfactory level of post-treatment fluency and rated their own speech fluency as good or fair up to 12 to 24 months post-treatment. The participants reported increased self-awareness, self-acceptance, and a reduction in their physical stutter. The participants were also rated on their percent of syllables stuttered pre- and post-treatment. The research was inconsistent if the combined approach significantly reduced the percent of syllables stuttered. While a combined approach to treating stuttering has been shown to be mildly effective regarding these outcomes, not enough evidence-based research is available to use a combined approach as a sole treatment approach for stuttering.
Although some research has been done regarding these treatment options, it is limited, and a lack of consistency exists in the results. Research can agree that all clients are individuals, and all individuals who stutter are unique. Therefore, a client-centered approach should be considered to determine the best individualized treatment plan. The focus of therapy should include all aspects of evidence-based practice. Using clinical experience can improve treatment options when clinicians are confident in the therapy they are providing. Ensuring that the patient feels important and valued is influential towards success in achieving treatment goals. The research conducted focused on the scientific evidence towards a specific treatment approach. Due to the lack of research, there is not enough evidence-based support for fluent stuttering, fluency shaping, or combined approach. More research should be conducted to determine the effectiveness of all three.
We have added our references for your further review of the literature presented. Thank you for listening to our presentation regarding different fluency treatment options.